I'm Anna Jefferson from Carolina Eye Prosthetics. I own and operate business. I work there with two other sisters of mine, and we have an office fully staffed at 7 people, which is really unusual for an ocularist office. Usually they're 2 to 3 man shows with a spouse doing the bookkeeping and the daughter or son answering phones and learning how to do the business. So we're unusual that we're so largely staffed. This is our building. We try to keep a nice, comforting atmosphere. I don't like having Medicare papers all over the place. I find it really intimidating and clinical. And we know that it's a very vulnerable place to go after you guys have had your eye removed from cancer or whatever reason. So we try to keep it as friendly as we can. Erica, she's a translator. She speaks Spanish. A lot of our patients are Hispanic. We're based in Burlington, North Carolina. And I'll let you guys just watch a little video that we did for our website. It's about 2 minutes, and then I'll get into the nuts and bolts. And since it's such a small group, I'm not going to do a Q&A at the end. Y'all just raise your hand if you think of something, and we'll just talk about it now, okay?
At Carolina Eye Prosthetics, I would describe the atmosphere as intense in the back. We're back there killing ourselves, making sure that everything's done perfectly. And in the front with our patients, that's where we get to blow off steam. The 3 sisters working together, we come in already knowing each other's strong suits and weaknesses, and we really feed off of that. We work really hard and with a smile on our face all the time. And you never know what to expect. It's never boring. Beautiful! We're very proud that everybody who comes in feels just greeted and welcome, and they know that we care, and they know that we care about what they're going through. I think patients appreciate that. It's very nice. I have to look at homes this time around, so it's nice. The girls make me feel at home every time I come, and they always ask me how I'm feeling, and it makes for a comfortable experience, and you want that.
The patients, they see, the fun part, but the real work is in the lab. We actually have a very tight schedule, and so we structure the day as best we can so that people don't have to wait on us. It's not like a doctor's appointment where you go in and see the doctor for 5 minutes after you've been in a waiting room for an hour. They sit with us, and we will work on the eye until it is perfect, however long it takes. When you tell somebody that you make artificial eyes, the first thing they say is, oh, that's cool, but they don't understand what goes into it. They think it's something you order from a supply company, and that's not at all what it is. It's completely hand-sculpted, hand-painted, and it's one of a kind.
Good. Ever since I come here when Lady was 9 months old, I felt like family, and I absolutely love watching them do their artistry. To see that and to see how much work that they put in it it's just amazing. How's your eye?
Good. Hasn't really bothered me that much.
How we get our good results is by opening the floor to the patient, letting them wear it a while, coming back to us and giving us their feedback, and that's what raises the quality. You have to be open-minded to your patients, and then that's going to get you the best result.
I don't think they left the couch all day. They just vegetated.
It's a very strange job in that you get to spend usually 5 to 6 hours with the person, one-on-one time. So you really get to know them. And at the end of the day, you usually get a thank you, you get a hug, and you don't really get that at other jobs.
I can't think about what I would be like right now if I hadn't found them. It's done so much for me. It's made me be able to live a more normal life up here, the way I used to up here. It's really helped me to deal with the whole process of losing vision.
I know that when I come to Carolina Eye, that I can walk away feeling my best, and I'm confident that they'll make sure that I always look my best.
To me, they're miracle workers. They made my daughter whole again. For us, it's more than just making the eye. It's about knowing that they're going to go home and look in the mirror and feel like they've gotten a piece of themselves back. Okay, so I'll just kind of get into it. And I'm going to bypass some of these slides since we're kind of short on time. Obviously, an ocularist is someone who fabricates prosthetic eyes. That's different from an anaplastologist who fabricates silicone prosthesis, ears, noses, orbital exoneration prosthesis. We just do eyes. I've done silicone prosthesis. I've done work I've done some anaplastology, but it's so labor intensive and my demand for prosthetic eyes is so high that I just send them down the road The person in Durham, who's about 30 minutes away, he was actually the one that did the movie makeup for X-Men, so he's got a big cast of Hugh Jackman's head. So that's why I don't do exonerations anymore. Okay, so how does one become an ocularist? You're lucky. If it's the kind of work you want to do, you just have to be lucky. That most of these folks are family businesses, like I said earlier. There's only 187 last I checked, and possibly Canada and United States, I'm not sure if that includes Mexico, that are board certified ocularists, so it's a very small group. You either have to be born into it, or many of the people that make prosthetic eyes are former patients themselves. For me, my apprentice that I have now just happened to be a good working guy who was a patient or a student of my husband's. He's a band director that kept coming back and coming back for school work. His parents never asked me to help him, which is a big bonus for me, especially coming from a family business. I know how tricky that is. And he was going to start chiropractor school, and I was overwhelmed. So he was there at the right place at the right time. We do get requests almost every 2 weeks about getting trained, and I've said no to every one of them, except for Armand, who's my new apprentice. A board certified ocularist is what you want when you have a provider. There are other folks that are able to file insurance, people that don't have any credentials at all. In some states can file insurance, so it's really important that you find someone who's board certified. And I believe Medicare is going to start requiring that next year. This is what a lot of people think a prosthetic eye is going to be shaped like. I've never made a ball-shaped eye. That's Hollywood. I think the Pirates of the Caribbean and the wooden eye. Even without an orbital implant in place, your eye is never a ball-shaped. It's always kind of, it's unique. I'll show you some pictures. So you can see, like, everyone's are different. We hand paint and hand sculpt, and it's all based on the impression that we first take when you guys come in. If you're not getting an impression every time you see your ocularist, when you go for a new fitting, then you may want to do some homework. The impression is very, very important when it comes to fitting. When people don't have impressions taken, that's where they have chronic mucosal discharge, where they're having to clean it out every day, take it out. Most of our patients are able to wear their eye continuously for 6 months to a year. And when I take it out to do their twice yearly polish, their implant, their bulbar conjunctiva is nice and calm, and there's no problems. There are some people that have chronic dry eye, so they may have to lubricate it a little bit more, but it should be low maintenance. And we never recommend flushing out your socket with anything. This is one of our patients. Can you tell which one is her prosthetic eye? I want you to raise your hand if you think it's this one that's closer over here. 1, 2, 3, 4. All right, so the rest of y'all obviously think it's that one. What gives it away is, if you can see above her eyelid crease, there's a darker shadow. That's called a sulcus deformity. So it's this eye right here, and it's that little area right there that gives it away. Some people, especially the older you are, have a deeper sulcus there, so that gives it away. But also, you can't really tell in this picture because I didn't get a good one, but her eye on this side is slightly pointing down because she's actually looking up at the camera a little bit. So when we have patients take pictures, or if they're a wedding or something, we just say, keep your head as level as possible. A lot of people will try to hide their prosthetic eye and do this to kind of hide it, but what it does is actually makes it more obvious, because that eye's not going to have that movement to go across the nose the way their good eye is. So when they take out your eye, and they do enucleations for folks that have ocular melanoma, unless they have the other treatments. When we see them, they've been enucleated. So they remove the eye, sever the optic nerve, and tie the rectus muscles, those are the extraocular muscles that move the eye, to the orbital implant, and then they cover the front of the implant with bulbar conjunctiva, which is just mucous membrane. So it's what's the inside of your mouth. When we see, and then we've got space for the eye to fit in. So you want an orbital implant to take up roughly 70 to 80% of the volume, while we do the rest. If you have 50-50 or 40-60, then you start having fitting problems. So you want a nice big implant. All right, so some general rules. A well-fitting prosthesis should be comfortable to wear without removing for long periods of time, with few exceptions. Unless instructed by a doctor, patients should not flush out socket with eye wash. An oil-based or silicone-based lubricant should be used for dryness. Visine, artificial tears are not going to do anything for you. Some people feel immediate relief, but you need something more viscous to stay on the prosthesis as the day goes on. twice yearly cleaning by an ocularist. Now, I used to do once a year cleaning, and then I changed my policy. The crazy thing is, I'm in a really, well, it's in the middle of North Carolina. We don't have huge cities. I'm not near Charlotte. I have patients that will drive 4 hours just for their prosthetic eye to be cleaned. So that yearly maintenance, that really makes a difference. And I am always surprised that people are so good about keeping those appointments. What if the patient has an allergy to the plastic? This is almost never the case. Doctors will sometimes say that, but I always tell doctors, be careful what you say, because what you've done is you've really limited their options. There's only 3 materials that I know of that prosthetic eyes are made of. One is acrylic, and that's what's most universally accepted. That's what we use. The other is glass. You can only get that in Germany now. The third is silicone, and that's only used by our friends, the anaplastologists community, because silicone is hydrophobic. It doesn't work well with the mucous membrane. But if you're going inside a silicone prosthesis where it's not touching mucous membrane, then it works fine. So if there's something that is suspected as an allergy, it's usually the plastic shot. There's fitting problems. Some people rarely have chronic infection, rarely though. And I had one person I thought had an allergy, and I could not figure it out. She'd been through several ocularists. Her last ocularist actually told her to rip up the carpet in her house. And I was like, what? And I took an impression, and it accidentally pulled out one of her plugs in her tears that the doctor placed a few months earlier, and her problems went away, so it wasn't an allergy. So yeah, when is it time for a new prosthesis? Well, when I first started this, my mentors, which were my uncle and my dad, they said, oh, you can get a new one every 7 to 10 years. I don't think that's the case. I think people's standards have raised. I think there's less surgery, and we're able to focus more on the patients, where it used to be more of a factory, new surgeries, and now I get maybe new surgeries 2 to 3 times a month. We're unusual that we have grown as a business. Ocularistry has dwindled, but we have grown, and I think it's because of the care we give our patients. Most people have a new eye every 3 to 5 years. I've got a lot of folks that'll do it every 2 years. As long as I can see what they are talking about, as long as I can identify the problem and say, okay, we're on the same page, I'm happy to make them an eye. But if I can't, if it still looks pretty good, I'm not gonna push them. Children under the age of 18 need a new eye every 1 to 3 years. There are signs of chronic discharge or recurrent infection. The plastic doesn't last forever, even if the fit is great. And some people, the fit really doesn't change much. The plastic won't last forever. It absorbs the protein from your tears, it becomes brittle over the years, and people that have chronic discharge, if the eye's like 10 or 12 years old, could be fitting great with the plastic shot. Following pregnancy or dramatic fluctuations in weight, whenever I have someone who is actively being treated for cancer, the eye is never quite right. And so what I do is I try to focus on just keeping them comfortable, maybe having come in more often for polishes, because I could refit it and fill it up, and a week later they're calling because they have such dryness. And I think that's all related to chemotherapy, so we just try to keep them comfortable. If the eye looks small, if it's rotated in the socket, so whenever you see someone who's got a prosthetic eye, if the eye is looking out, it's because their eye is upside down. Unless it's just really old and they hadn't seen an ocularist in a while. If it's falling out on its own, if you rub your eye, it could fall out. If you rub your eye, it could rotate. If it's rotating on its own or if it's falling out, then you give me a call. Sometimes it's a fit. Sometimes they need to see an oculoplastic surgeon for lower lid tightening or ptosis correction. Most patients will have their eye removed to melanoma, glaucoma, diabetes, or trauma. You guys all know about the first one. I will tell you, I don't know if you guys have ever seen The Handmaid's Tale. One of the handmaids has her eye removed because she kind of mouthed off, and there's a Bible verse that says it's from the Sermon on the Mount, if your right eye offends, pluck it out. I've had 4 schizophrenic patients remove their own eye because of that Bible verse. So melanoma is very traumatic. I'm impressed by anybody that can go through that and still have a smile on their face, but we get people from all sorts of places and things. I had another one. He lost his eye. I've had plenty of BB gun accidents, but this one was Christmas Day, 1954, Red Ryder BB gun. So we had a laugh over that. There are 2 types of eye removal surgeries, evisceration or enucleation. You guys know enucleation. Evisceration, that's for, you can't use it for cancer, folks, but they'll often do eviscerations for painful blind eyes, some injuries, but it's where they take the intraocular contents out and they leave like the Tenon's capsule where the muscles are all attached. So all you have to do is put an implant inside the eye, it's not functioning. An evisceration, that's done too. But you tend to have better movement and the recovery time is less. This is one of my cancer patients. This is 6 weeks after her cancer, and you can see she's got her eye removed. What she's got in there is like a large contact lens. It's called a conformer. And what that does is it maintains those upper and lower fornices, those upper and lower lid pockets which hold the eye in. So we like to see a nice pink, nothing red, nothing inflamed, no exposures on the implant. And this is her afterwards. Now, we make the eye in one day because our patients travel from such a long ways. People do get a little bit more swollen by the end of the day, and one of the things that as an ocularist I don't like about this picture, and this is the end of the day, so I've been messing with her and she's a little puppy. You see where the light is on the pupil. As an ocularist, that light needs to be centered. So that means it's pushing out, all that swelling up there is pushing it down and out ever so slightly, and that reflex is off. And incidentally, when she comes in, or when she came in a year later, she started showing signs of post-enucleation socket syndrome. Melanoma patients, I think it's because a lot of them are over the age of 55, they have what's called post-enucleation socket syndrome, where there's more of a sulcus deformity in the upper part. Their eye has sunken down a little bit, and a year, maybe 18 months after surgery, then I might refer them back to the oculoplastic surgery to have fillers or orbital wedge implants. So when you have that sulcus up there, if you have an orbital wedge implant, they can put that down there and help push the eye. Now look what happens when I push my eye up. You see how it fills up that top sulcus? So they can do that, but they wouldn't do it so soon after surgery. This is just an example of what we see. And these are always red flags. The happiest patients I get are the ones that come in right after surgery because they've grieved to some extent. They've accepted it. They're ready to move on. And they've looked at themselves in the mirror without anything for such a long time. And so when they get their eye, there's usually tears. But when I have someone like this, not this gentleman in particular, he's always a happy camper, I get a red flag because he's been looking at himself that way for years. And there's something called old eye syndrome. And that's where you've come to accept that as the new you. And so I had a patient that was like that, except her eye was more closed, but it was looking out. And to me, I was like, oh my gosh, we can do so much better. So I opened it up and I made it look straight ahead. But she called back the next day and she said, it's bug-eyed and it's cross-eyed. Now, can you see why she would say that? If her eye was halfway shut and it was looking down. And what I've done that's changed is I've approached those folks a little bit differently. Whereas before I'm like, all right, let's get to work. I'm not a person with small talk. Let's get to work and get this going. I prepare them. This is going to be a big change. And I do not want you to call me the very next day. I am happy to work on your eye, but not until 3 months after you've worn it. And you have to wear the eye and do your homework. Otherwise, this isn't going to work. And so that generally has done it. It's very unusual. If the patient has done their homework and worn the eye for that whole time, it's very unusual that I have to make changes. Usually it's like, okay, you were right. I went and took some time, and it was weird at first, but I'm good now. This is an example of some movement. This isn't perfect movement, but this is fairly typical. And I'm not going to show you because I don't know how to do the video. But generally speaking, it's very subjective what kind of movement your eye's going to have. Usually when I'm looking at a patient, I'll have them follow my hand and they'll stop. The prosthetic eye will stop right about there while the other eye continues to go. It's so maybe 50% movement. The best movement is when you have someone like this who's got a large globe. That's a blind eye. It's churned out. There's nothing telling their brain that sight's going to come through. So most people with blind eyes, usually it'll wander out and they'll start to get calcified. You get the best movement with them, but they are the trickiest fit. Remember what I said about orbital implants? I want something that takes about 70 to 80% volume. You got something that's taking 100% volume. It leaves a very challenging job for me. I have to make something extremely thin for it not to be noticeable. And if you can see, where the cornea is the thickest part of her globe. So how am I going to make an eye that's not going to vault that eye anymore? I still have to have 2 layers. I have to have a white layer that I paint on and a clear layer that goes over the top of the white layer. So I'm looking at something about 1 millimeter thick, which is super duper thin. And if during the pumicing process I go too far down, it's going to go right through that paint. So they're very challenging to make. But we did it, and as you can see, that thick part of the eye is still a little open. So what I'm going to do is I'm going to have her go to a oculoplastic surgeon for a lateral tarsorrhaphy, where they take the lower lid and tuck it and pinch the upper lid with it and close that fissure a little bit, so it'll be something a little bit more shut like that. Also, with these type of eyes, unless you really fit them well, people may not be able to tolerate them because those globes are so much more sensitive than an implant. This is an example of a lady who's got a blind eye. That is her old eye. I think it was like 10 years old. You can see how different it looks than her good eye. That's her blind eye. So that one's different. That's turned in a little bit. You can see it just closes up a little bit. That's a little bit easier to fit because it's smaller volume. And there's her after. This is a person who's never been fitted with prosthetic eyes before. She said she wanted to treat herself. She's been blind since she was a kid. The fun thing about these folks is you can change up the color, and I'll show you those in a little bit. All right, so pediatrics. I work a lot with kids. A child can be seen for a fitting as young as 6 weeks, although if they are congenital anophthalmia, which means a child who was born without eyes, then I can see them if they were a day old, because we have to start the work to build up a socket to hold something in. A lot of ocularists don't work with these folks because these are the most challenging cases. Congenital anophthalmia. It is from birth. It's not acquired like people have had enucleations. So I see them for microphthalmia, which is a underdeveloped blind eye. It's usually just a little smaller than a good eye. And retinoblastoma, which is the most common form of ocular cancer in children around the age of 2. We work with Duke, so we get a lot of Duke kids. And I actually have some from Carol Shields, though, incidentally. So this is actually, I would like to replace that word with anophthalmia, because what I find is microphthalmia, as long as there's a blind eye back there or something back there, their bony orbit will grow. So I don't do this early treatment the way I used to. But this would go for anophthalmia, and just pretend there's no eye there. But you can see how you've got kind of an acorn-shaped socket, which makes it very difficult to hold anything in. So the priority is to put something in there to put pressure on the inferior and superior fornices to grow those pockets to hold something in. So we'll start with a small conformer and build it up. If I can see them once a month, I will. It's really inconvenient for the parents, so sometimes I'll make conformers if I feel like they're able to do it themselves. Some parents are completely intimidated by it, which actually is not good for the patient. It's better for parents to be actively involved, because there won't be so much of a taboo about their child having these devices. I have one patient whose mother was afraid to even look at the impression, and as a result, the child never really accepted themselves. So we really try to get the parents to be part of it. But I had one couple, they came up once a month. They were 4 hours away. So we expand it until we can get good symmetry. You see how small it is over there. And this is all with expansion therapy. We also have them manually stretch out their eyelids. I know it sounds kind of crazy, but it actually does help. This is a baby. She actually was clinically microphthalmic, so she had a tiny bit of structure, although if you looked in her socket, you wouldn't see anything but pink flesh. But you can see how small it is. I saw her, I think she was 9 pounds here. And we started doing conformer expansion therapy and stretching her lids. You can see how much better she looks there. That's with a conformer in place. Eventually the conformer, that clear shield that I made, got so large I couldn't pass it through the orbital fissure, the opening. So I called their doctor and I says it's time for some implant, and he put in dermis fat graft to build it up, and that's how she looks. And I've got a video of her here. I'm not going to play it, but what you'll see in the video is that this one sticks open. It doesn't close. But as she grows, she'll start to have some more lid closure. And what we want is we want to stimulate growth. So she's one of the rare kids that I have that are extremely cooperative. Most of the children I work on don't want to be worked on. So it's really, really tricky. So I don't believe in EUAs. That's when you meet your surgeon at what's it called? An operating room. No, operating room. This is when they do the surgeries and stuff. So I'll go over to Duke sometimes, and they're like, hey, we're putting this kid under. Why don't you come over and take an impression? And I'm like, okay, I'll go. But you really don't need anesthesia. And I know some ocularists will actually advocate for anesthesia just for the impression, and I think it's irresponsible. You can take the impression in the office, but you just got to hold down your kid for a minute. It doesn't hurt. They don't understand why you're doing it, but I feel like that's more responsible than putting them under anesthesia. But you have to have trust of the parents. So I spend some time talking to the parents. This is what we're going to do. It's not going to hurt them. I show them pictures of kids that are just laid back 2-year-olds. When I have a laid back 2-year-old, I take a picture of them with the impression in their sockets. They can see it's really not a big deal. When you have a young baby, you can do it very quickly. As long as you put a binky in their mouth, they're very happy. The best result with the least amount of trauma to the child, sometimes having the parents in the room is traumatic to the child. So what I will do is I'll try to separate, and I think, you know, that's something I might have to think about with Armand, because my apprentice, because he's a male, taking the child outside, they do better without their parents a lot of times. So we'll usually have a third party there, but I spend a lot of time talking to the parents before we do that. And if the child is not willing to cooperate, then I'll tell the parents, you're going to be invited back there, but you're not to talk, you're the muscle. After we take the impression, you go back out to the lobby, and then I'm going to give him a puppy. I've got a puppy I keep at my office to make him happy, and then I'll send him out. So boundaries are really important with parents to work with kids. And I found the more assertive I am about those rules, the more willing people are able to follow them. I can't really negotiate with that, because it does get traumatic with the child if you've got parents back there acting out. And additionally, I have, whenever I have an adult who is very self-conscious about it, I always ask, how did your parents do when you lost your eye, if there were childhood incidences? And the people that associate their prosthetic eye with shame typically have the hardest time with it. Back in the 50s, 60s, it might have been that their mother was like, don't ever tell anybody you have a prosthetic eye. And I think it's really important to celebrate that this is just a part of you, to accept it. And I can't tell you how disappointing it is when I have a child back there who looks pretty good. It's just a piece of plastic. It's never going to be perfect. And they're really excited, and their mother comes back there and says, can't you get that right? And I just see it fall. It is a prosthetic eye. It's not the real thing. So we really try to encourage acceptance and not to be afraid of it. It's just a different way of living. Their eye might pop out of the beach. Put it back in. Not a big deal. Eventually, trust with the child will come, and then cooperation. I work with some autistic children. That's challenging. I am not a patient person. But what I find is with my autistic kids, if I give them a job, they do better. So I'll make them throw something away from me. I'll make them go get something for the lab for me. I need you to go do this. And that empowerment makes them trust me a little bit more, and cooperation follows. This is a baby with microphthalmia, so you can see that tiny little blind eye. I didn't have any cooperation with him. But what I'll do is I'll put in like a wax model, and then I'll let them play at my little station, and then I'll kind of get on the floor with them and see where their eye is. And I can do pretty well with just a lot of guesswork. This guy, he's a great guy, always a little nervous. So I make him polish his eye when he comes in. And he's doing better and better, and then we do the professional job afterwards to make sure nothing's been missed. This is a kid who's cooperating. He's about 3 years old there, and she's putting in a trial conformer. That's that clear shield that I was talking about. This is someone that's never had treatment, but it wasn't like starting from scratch. She had some structure there, so I didn't have to be so assertive with stretching her eyelids. She had an orbital implant, and we had pretty good symmetry, but if you can see what this shows, you can see where she's got like a little pin light reflection there, and it's a little bit smudged, and that's because she doesn't have full closure, so she's got dry eye. As she grows, that might get better, but she's going to have to lubricate her eye. These are siblings. Anyone that I tell that I work with children, they get so upset. Oh, the children, they lose their eye. Don't feel bad for the kids. They do great. Feel bad for the older folks that have their eye removed. And these are siblings. She was born with teeny tiny microphthalmic eyes. He was born with larger microphthalmic eyes. So he's got a better base. And you can see in this picture, her eyes are always going to be a little bit small until we're ready for orbital implants, which I'm not ready for. I'll start telling her about orbital implants when she has chronic dryness, mucosal discharge, and if the eyes are falling out. Those are both prostheses. You can see how good his are because he's got larger blind eyes supporting it. And these kids are highly functional kids. They don't go to special school. The only thing you have to be prepared for is they're going to just touch you all over. They're always hanging on me, and I love that because that's my love language is touch. But they are great kids, and I don't see any reason why they would be called handicapped, honestly. This is another, she actually was born without eyes, so we stretched out her sockets, and she went for brown because that's what she was born with, but we tried blue one year. She's got some entropy, and you can see her lower lash line wants to fold back on the prosthesis. That's a little irritating. Eventually, she might have that surgically corrected where the oculoplastic will have those. I don't know how they do it, but they're able to get those eyelashes off the prosthesis. But they're always going to be a little bit small. And this is a patient of mine. She is Medicaid. A lot of ocularists, if they're Medicaid, that means we're going to order them some stock eyes. We make customized for everyone, regardless of their insurance. And I like this picture of her because you can see this eye is sunken back looking in comparison to this eye. If you took the prosthetic eyes out, they would be the same size. They are stock eyes. Stock eyes mean there's no impression incorporated. It wasn't custom to fit. And she has fitting problems with it. But she's Medicaid, which is what some people do. So I said, well, we're going to make a new pair. But if you took out this eye and compared it to this eye would be a whole lot larger and thicker because we're compensating for the volume loss that has on her orbital implant on this side. The funny thing is she's Hispanic. She says everybody said she looked white after we went to the green eyes. We had a good look at them. This is another one. She's a Russian orphan. And she was always, my dad actually worked with her. And she had brown eyes cataracts when she was a baby in Russia. And so I was like, why don't we try some blue? And it looked really good. I thought she looked like a Zooey Deschanel from New Girl. I don't know if you guys know that show. This is a picture of a guy who has one eye that's been enucleated, removed, and the other one that's still there, and you can see the difference. So the biggest challenge with him is symmetry, because it's not quite similar on both sides. But I thought we had a pretty good result. He is a beautifully ear-trained pianist. So you'll often find that there are a lot of, it's like, I don't know if it's because they've lost their vision, they've compensated otherwise, but I have a lot of musicians that are blind. And so that's Fifi, that's our dog that I bring to the office. I started bringing her a couple of years ago. She's an emotional support dog, which you don't have to have much to qualify for that really. But whenever I have a kid who's upset, especially with the girl, she goes right up to them. In fact, there's been times where I've been trying to work with a child and she'll come sit on their stomach when I'm trying to take their impression and comfort them. I'm like, we have to get her out because she knows I'm going to make them upset. And when I tell parents, I'm like, look, don't tell your child that you're bringing them in to work on the eye. Tell them that they're going to go see Fifi, and that's what they focus on. There's less anticipation. This is a really good example because this was a traumatic injury, and he had a lot of volume to his globe. So he doesn't have any kind of volume asymmetry. It looks beautiful, and he's got wonderful movement. Very difficult to fit, though, because it's such a thin shell. And this is Libby from earlier. This is a father-son duo. They both have retinoblastoma. Some strains of retinoblastoma are genetic. So we do have a few folks that come in and I polish the dad or the mother, and then we polish the kids. And on one occasion I had a little girl who was, she was really, really nervous. And I told her, I was like, well, your dad is really scared. I need you to show him how to be brave so he doesn't cry. And she got right in that chair and let me go to work. This is another example of a child with microphthalmia. She was a little girl adopted from Russia too. And you can see how nice and white her blind eye is. It's not irritated at all. This is the same girl a few years later, and you can see her eye is pretty red, and that's because the eye that she's had, she's outgrown. So I made her a new eye. And that's because we waited 5 years. And I don't know if I was as strongly worded about you need to come in every 2 years, have an eye made if you're a kid. Now I am, because I feel like when someone goes for an amount of time with something that's less optimal, that's what they consider to be the normal. And I think it's really important, those adolescent years, to have the best possible look you can. This is a little girl who had her eye updated. I tend to see her every 2 years. And I thought she might need surgery to fix that upper lid, but she just needed a better fitting eye. So the way we make an eye is we use the modified impression method, which was developed by a medical illustrator named Lee Allen. And basically it just means you're taking an impression. Before then, it was mainly empirical fitting, which is the best guess without an impression incorporated. So if the eye was looking in, you'd add a little bit to the corner, straighten it out. But of course, you'd have fitting problems because you didn't have a close fit with that orbital implant. When you don't have a close fit with that implant, there's space for tears and mucus to collect. Also, you can have it where it's rubbing in directly on the implant, and then you have an orbital implant exposure, which means a trip to the oculoplastic surgeon. So it's really important to have that custom fit. So this is someone after surgery. You can see it's a little pink and it's still kind of puffy. And this is a patient who's probably been enucleated for a year or two. And you can see how nice and calm and almost white looking that tissue is. And you can see the contour of that orbital implant right here. But that's what you want to see. So we take an impression. The old impression was alginate, which can tingle a little bit, maybe burn a little bit. And since then, I've used what's called vinyl polysiloxane. It's very comfortable for the patient. You don't have any burning. The only thing is if there's any hint of an exposure or there's any kind of suture, it will grab on and not let go. So a lot of your older guys have been making eyes for years are afraid to use that stuff. All you got to do is inspect your socket. But folks that do have an exposure, I can take an impression with that old stuff. I just don't like it as much. So there's one of my happy campers getting an impression. That orange stuff is that other material I was talking about. Give her a dog, she's happy. And we'll take that impression and we'll make a negative mold. And where the impression stem sticks out, that's where a chimney is placed, so we can pour hot wax in there. And we use wax so we can make changes to it until it's looking straight ahead, the opening matches, and it's comfortable to the patient. And we try not to deviate from that impression. Sometimes I do deviate from impressions. Some people don't use impressions well. They don't work well with impressions, but it's a very, very small amount. I think maybe 5 of my patients out of thousands do better without an impression. So you always start with an impression. And then we hand paint the eye. I use what's called a paint shell. So I have the white part and then I've got a clear part that snaps over top of it. The reason I like this is because I can put the eye in before the final cure. The patient can see it and make sure that they're happy with it. And if I have a patient who's well, if it's a male, I try to get their wife or their daughter because they're the ones that are going to find something wrong with it. So I try to include whoever they need to include to find to accept it. And if they have something about it they don't want or they want me to change about, maybe the color is not to their liking, I can take it out and change it and paint over it and get it until they're happy with it. I've spent 3 hours painting an eye before, but that's what it works, or that's what it means for some people. Then we cure the plastic with pressure and heat. So we put it in a flask and a press and then put it in a pressure cooker and cook it for about a half an hour, and then it comes out really, really rough. So we have to drill it down, sand it down, pumice it down, and then finally do a polish. That process takes about a half hour after we've gotten it out of the flask. We make it in one day. So our patients come at 8:30 in the morning, and we usually wrap up in the afternoon around 3 or 4, and we'll put our patients up at a hotel to help with the trip. I don't travel. I've traveled before. I can tell you firsthand, if the ocularist is on the road, the quality might be compromised. Whenever I go from one room to another, it takes me about 2 weeks to adjust to the light until I'm able to paint the colors the way they need to be painted. Sculpting, when I change my tools, those little things like that matter. When I've got a tool that I'm comfortable with, it might take me longer to sculpt with another tool. Also, with our office, I have full lab support, so I'm able to see a larger volume of patients. And so what I found is I'm able to help more people if I stay put. And so we help out with putting them in hotels or something. And we're still kind of figuring out how to help with mileage. But basically, people don't mind driving if they think they're going to get a better product, is what I found to be true. Basal cell carcinoma, sarcoma is the reason we make facial prosthesis. For time, I'm going to go through through this quickly. This was an accident, a motorcycle accident. He was just a really positive guy, and I thought it was such an interesting case. Since he was blind, I decided to make something sort of like a sleeping mask so it would be easy for him to apply. It was very challenging, but that's what I came up with. And I said, bring a picture of yourself so I can see who you look like, and if you forget, we'll just do Brad Pitt. But he brought a picture in, so, and he wears glasses to kind of, because when you have a silicone prosthesis, your do or die is the margin. You have to blend that margin, and that's always the giveaway. So we try our best to blend that, and sometimes wearing glasses, especially when you have prominence issues. One side was more prominent than this one, so I had to make one side pretty thick. I'm going to go through this. This is just a pegged implant. Is something they do to help with movement. It's a high rate of complications, and I doubt anybody at this conference has been pegged, so we'll go through it. Novelty prosthesis. I wanted you guys to see these because you might recognize someone. But yeah, I always encourage them to get the real eye made. Like, let's make it, because you might want to take your grandma to Sunday school, you know. We have our Marine. I had a patient from the same town as this guy, and my other patient said, this guy has a spider in his eye, and he never wears, like, he always wears it. I'm like, I made him a good eye, but he she went and had a peg made on her implant to help with movement. Beautiful movement, looks so natural. And she's like, well, I want to put a butterfly on it. Like, okay, so I texted the surgeon. This was not my recommendation. It looks so natural. And like, why do we want to put a butterfly on it? But that's what she wanted, so we did it. Harley Davidson fan. It's hard to see, but we fit the entire Harley Davidson motorcycles on there. And you guys might know this guy.
Ryan.
He called Ryan Gibson. He's a good kind of crazy, that's what I think. He and I speak the same language. We have a very like-minded. And he called me when he first had his eye removed, and he said, Anna, I'm going to make you famous, but I don't want an eye that looks like my other eye. I only want Bayern Munich. And I said, no, I will not do it unless you get your healthy eye made first. And he insisted. I was like, okay, fine. But I thought he was joking. As soon as he got that eye, I got all these crazy articles blowing up. Of course, still nobody knows who he is because it's a European soccer league, so who knows. But he called me a couple years, no, it was only about a year and a half later, and he says, Anna, I'm coming in on this day, and I'm bringing a film crew, and you're going to make me another eye. I'm like, okay. Looked at the schedule. All right, we got to move some things. And I'll show you what they came up with. Have any of you guys seen his video?
Yes.
Have all of you seen it? All right, it's only about a 2-minute video, but it's really well done.
I'm Ryan Gibson. I'm from Columbus, South Carolina, cancer survivor, and I'm a soccer fan. How does a Southern boy end up playing for Bayern Munich? I mean, my grandfather was stationed in Germany. My dad was born in Germany. I've seen Bayern play live 3 times. It's arguably one of the most historic teams in Europe. We're going to Carolina Eye Prosthetics. I'm getting a new eyeball today.
It's what my husband's ever done too.
Is it getting a fancy one or is it just getting a regular eyeball?
Oh, the regular one. Oh, you get a fancy one?
Yeah.
What's the fancy one like? Whoa.
Same reaction I get from everybody. It started in January of last year.
Ryan's really young, and it's a really scary diagnosis.
Ocular melanoma is something you hear about, but you rarely ever see. Because only 5 out of every 1 million Americans get diagnosed with this. The day that I decided and told the doctor I was going to have an operation, I'd already had the idea I'm getting a Bayern Munich eye.
And that's one of the coolest things I've ever heard of. That's turning absolute negative into an absolute huge talking piece for not only his cancer, but for soccer and for Bayern Munich as well.
Soccer's helped me tremendously in this, about as much as any doctor has. The camaraderie. I love soccer because of the action, the beauty, the flowing nature. I see the sport as a symphony. It's like Beethoven's pick. It's going like this. I mean, the beauty of that sport, there's nothing that can compare to it.
Ryan Gibson ist die Nummer 1 Fan für Bayern München hier in Charlotte.
Granted, I'm going to talk trash the whole time, but that's when you forget everything. Cancer, having one eye, this, that, or the other. It's always been my 90 minutes of peace.
He's funny. the day that he came up, I put him on the schedule at 8:30 because that's when I like to start my day. But it was 10 o'clock, and I was complaining. I was like, I'm going to kill him. He is late. And he was taking a cell phone video of this whole experience, and he comes in right before he opens the door. He said, she's going to bitch at me because I'm late. And I was like, anyway, it's funny. So anyway, that's my presentation. What kind of questions do you guys have? Y'all are easy.
I kind of have a question.
Yes.
He had his prosthesis placed in February? April.
Mm-hmm.
And to me, it looks like it's sinking back. Does that happen, or is it just
Yes.
me,
Who's your ocularist?
Drew?
Cincinnati.
Cincinnati.
Drew,
I don't know if I can think of it.
Did you have a follow-up appointment? How long after your first appointment was your follow-up appointment? Okay, so that seemed kind of appropriate. When were you enucleated? February. Okay. When he first made it, was it open? Well, I imagine if he just built it up a little bit.
It's not, it just almost looks like, to me anyway, that it's, the whole thing has sunken back.
Right.
Does that make sense?
Yes. Okay, so that's different than just a droopy upper lid.
Yeah.
As you heal, as the swelling goes down, there is volume loss. And I talked about it earlier about post-enucleation socket syndrome. A year or so later, I might send people back to the oculoplastic to have fillers done. I don't know what they could do to help people that have prominence issues. A sulcus deformity, they can put fillers in, or the orbital floor implants. But typically, everything's a little bit set back, and that's because as you heal, that orbital implant settles back a little bit. I would not recommend, it's not like I would say get a secondary implant surgery. You're always going to have some volume loss. If you're lucky, you won't, but sometimes that's the situation. And it's more noticeable to try to compensate for that volume loss by building up an eye. It's going to look bug-eyed. So the best thing you can do is wear glasses where the frames kind of sit right across that upper lid, and that's going to be less noticeable. And as always, there's no bigger critic than your ocularist, yourself, or the wife. So I think it's a really good result.
Thank you.
You're welcome.
So did you say you third generation at this? Your grandfather's?
Oh, funny story. I assumed ownership of the business at the age of 30. The year before, my uncle and my dad worked together. They hated each other at the end of it. My uncle and my dad split up. It was really nasty. There was no non-compete. My uncle opened up down the road. He's on the same road that I'm on. And my dad was diagnosed with ALS that year. So we like to say we are survivors of family businesses. And since we all have similar patterns, I will not be bringing my children into this because I want to be speaking to my sisters at the end of the day. And being from a family business, I know you can have success, but happiness is sometimes you're in conflict with that. That's really unusual. And in an industry as small as ours, that was a huge slap in the face. But because of that, we have had to evolve. And we do things on a different level, I feel, because of fear of losing business. And I did lose a lot of business that first year. So I got board certified. My uncle never did. And I staffed differently. One of the common complaints I have for patients is we have an ocularist that's trying to be secretary and do the bookkeeping and do the insurance filing when we really need our separate roles. Otherwise, things don't get done correctly. Mm-hmm. So, yes, ma'am.
Thank you for your passion.
Oh, thank you.
It's
Thank you.
awesome.
Thank you.
Yeah.
The bedside manner comes across.
Oh, thank you.